Hi, my name is Dr. Ann Rutkowski. I am the co-founder and board member of Cure Congenital Muscular Dystrophy and the director of the Congenital Muscle Disease International Registry. I have the pleasure of introducing Dr. John Bach, who is a professor of neurosciences and the medical director for the Center of Non-Invasive Mechanical Ventilation at Rutgers, New Jersey Medical School. Dr. Bach is a pioneer in the use of non-invasive ventilation in both children and adults with neuromuscular conditions, and we are really pleased to have him speak to us today and provide us with this webinar that describes how he assesses and diagnoses breathing issues in children and adults with neuromuscular issues. In order to get the most out of this video, it is important to go through the following brief tutorial to understand some of the key words and concepts that Dr. Bach uses. A person with muscle weakness may develop breathing issues over time. Some children who are more severely affected have breathing issues directly at birth. All children and adults with muscle weakness must have their breathing assessed regularly to determine 1, if they need to start an intervention, or 2, if they are already on an intervention, such as BiPAP or a ventilator, whether their settings need to be optimized or changed, whether they need to introduce the use of a cough assist, and whether they need to change the number of hours that they are currently using their ventilatory support. Next slide. In babies and toddlers, issues with breathing function may manifest as poor weight gain and frequent chest infections. Some children who are born with breathing issues need breathing support from birth. In some kids, breathing issues develop over time, and this onset is gradual. A child with breathing issues secondary to muscle weakness will not look short of breath, nor will they complain of having difficulty breathing. Next slide. In school-age children, to determine if there is a breathing issue, a forced vital capacity or spirometry needs to be performed starting at age 5 years. This is performed in children who are not currently tracheostomized or on ventilatory support through a trach. Forced vital capacity can either be tested in a doctor's office using a handheld device or in a pulmonary function lab. If performed in a pulmonary function lab, it is called pulmonary function testing, or PFTs. Pulmonary function testing was developed to diagnose and distinguish obstructive versus restrictive lung disease. Obstructive lung disease is asthma and emphysema, and restrictive lung disease occurs in neuromuscular diseases. However, in your case, or in your family's case, we already know that the person has a neuromuscular condition. Therefore, they have restrictive lung disease, if they have any lung disease typically, especially if they are a child. And the main question is not what type of lung disease do they have or breathing issue do they have. The question is whether or not their weakness has already resulted in a decline in their breathing capacity. In a pulmonary function test lab, a patient is given a cardboard tube to blow in and out of and is given several commands by a respiratory therapist. These tests include the measurement of forced vital capacity. The majority of pulmonary function testing results are not used in a neuromuscular patient to trend their disease over time. The main value that is trended is the forced vital capacity. Forced vital capacity is abbreviated FVC. And as I've already stated, it can be tested in a clinician's office using a handheld device, or it can be tested in a pulmonary function test lab. If it is tested in a clinician's office, it can allow that clinician to use that data on the spot to make changes in a patient's care. In the United States, testing of forced vital capacity is typically carried out in a pulmonary function test lab with a clinician accessing the data at a subsequent patient visit. As the CMDIR obtains more information on breathing function in various forms of congenital muscle disease, the CMDIR can work with international clinician groups to look at trends in forced vital capacity and sleep studies over time. This type of data mining is very helpful to decide if breathing issues change over time. For example, in collagen 6 CMD, it is now known that breathing function declines annually at a certain percentage change in forced vital capacity in patients with the more severe form called Ullrich congenital muscular dystrophy and in the intermediate form. Knowing this information can help you plan how to anticipate when breathing interventions may be needed. It is important to know that breathing issues do not start during the day. They begin overnight. When we sleep, we all breathe more shallowly. This means we take less air in. If you have muscle weakness, the amount of air you take in is even less at night. And this means that the amount of air you exhale is also less at night. The main purpose of breathing is not necessarily to breathe in oxygen, which is really only an issue if you're at high elevations, but rather to get rid of carbon dioxide, also called waste gases. To get rid of waste gases requires a certain amount of air to exhale. With less air to exhale, carbon dioxide levels are trapped in the bloodstream, and the level of carbon dioxide starts to rise. There is a very simple solution to this problem. Increase the amount of air that is inhaled, which means to also increase the amount of air that is exhaled, and thus release the carbon dioxide in the exhaled breath. Machines such as the BiPAP machine or a ventilator provide this increase in air volume. A sleep study is a test that was designed to diagnose obstructive sleep apnea. In other words, it was not designed for neuromuscular patients. It has been used now in patients with neuromuscular disease to provide answers to two questions. And there are two major types of abnormalities that can be diagnosed on the sleep study. Sleep disordered breathing, so number one, is there apnea or pauses in breathing when this individual sleeps? And is there evidence of hypoventilation or underbreathing, which over time leads to a slow rise in carbon dioxide? In order for a test to be of benefit to a neuromuscular patient, carbon dioxide levels must be monitored during the sleep test. Sleep tests can be done in the hospital, and now most recently are also being done in particular in adults in the home setting. There are several different ways to measure carbon dioxide levels. This can be done through an arterial blood gas, which involves placing a needle into the artery in the wrist. The carbon dioxide level can also be approximated based upon a venous blood draw, a typical blood draw, and can also be measured in the air a person breathes out, either if intubated through an endotracheal tube or if not intubated through the nose. This last type of carbon dioxide measurement is called an end-tidal carbon dioxide, and it stands, or CO2 level, standing for carbon dioxide. This end-tidal CO2 can be measured in the office and is typically measured by placing two small prongs near the nose, and that measures the percentage of carbon dioxide in the exhaled breath. You will see in this webinar that it is Dr. Bach's practice to check the following when a patient is seen in the office. He wants answers to the following questions. Number one, is breathing affected? To do this, he checks the forced vital capacity. Then the second question is, what is the trend in breathing function? So in order to know the trend, one has to check the forced vital capacity over time at each visit and see whether it is remaining the same, improving, or declining. Third, is this person retaining waste gas or carbon dioxide during the day? The way to check this is to check an end-tidal carbon dioxide level measurement in the office. And then fourthly, is the cough weak? And the way to check this is to do a peak cough flow. So that will allow Dr. Bach and any clinician to determine at that point whether in fact interventions need to be started or need to be changed. Typically, physicians outside of Dr. Bach's practice may perform these tests not in their office, but as part of their pulmonary function testing, and then use the data generated on other visits in order to provide the patient with advice and instructions for further interventions.
Now, this is a child with SMA type 1. SMA type 1 is the most severe neuromuscular condition that there is. These children are born paralyzed, and it's also called Wernicke-Hoffmann's disease. They are 15% die before 6 months of age, or are continuously respirator dependent before 6 months of age. But typically, the patients develop a cold after they're not protected by their mother's antibodies anymore, between 6 and 18 months of age, and then because their cough is so weak, they develop pneumonia and go into respiratory failure, and either die or they get trached. And again, just about always before 18 months of age. But the reason I put this child up here is because every child who has paradoxical breathing, so in other words, when we inhale, our diaphragm goes down and our belly goes out. Normally, our chest goes out also. But when a child has any neuromuscular condition and the chest muscles are not working, and so the chest sinks in instead of going out like the belly, that's called paradoxical breathing. Again, when the belly goes out and the chest sinks in, that is paradoxical breathing. Any child that has that and is not put on nighttime ventilation will end up like this child, with lungs that simply do not grow, and this child will certainly be dead in a matter of weeks because he was obviously not put on nighttime ventilation, and that's what happens when you don't. Now, these two children have severe SMA type 1. They have been continuously respirator dependent since 4 months of age, getting air through the nose. They have 0 milliliters of vital capacity. When the older boy was 2, mom got pregnant again and had another child with the same condition. Both have been continuously respirator dependent since 4 months of age. And here they are in 2010 at Yankee Stadium. I saw them 2 weeks ago, but I don't think I took a photo. No, I didn't when they came in, unfortunately. Now they're about, one is 19 and the other is 17 years old. They're actually much bigger than they appear in this photo here. Dad is a lawyer and mom is all the way on the left there. They're really very bright people and wonderful people, but they weren't very fortunate because they had 2 in a row, and these are the only 2 children that they have. At any rate, I told them 19 years ago that their older boy there would be dead within a year if he didn't get a trach tube. But they refused the trach tube, so I had to use the methods that I use on adults for them, and they're still alive today. In fact, they've been really very healthy all of these years. There was another patient, too. This little boy at the age of 1, I also told his parents that if he didn't get a trach tube, he'd be dead within a year. Now he's 20 years old. Here is trick-or-treating when he was little with his brothers. His last hospitalization, he was 16 and a half. He came in. We had to intubate him for 24 hours because he was exhausted. And then we extubated him back to his nasal ventilation, and he went back home. And I haven't seen him now in 3 years. But I know he's fine because his parents keep in touch with me. This is a boy with muscular dystrophy, Duchenne. The most severe case I've ever had, he's been on nasal ventilation or mouthpiece ventilation since he was 12 years old, 24-hour vent dependent since he was 14, using a mouthpiece during the day, and he uses a lip seal at night. Anyway, here he is using his mouthpiece for ventilation at the age of 41. The average life expectancy now for people with this condition is 40, but nobody dies from respiratory complications anymore. But people with muscular dystrophy also have weakness of the heart muscle. Some congenital myopathies, the heart muscle is involved, and in others, it is not. So if the heart muscle is not involved, and if the left ventricular ejection fraction on the echocardiogram stays normal, then you have essentially a normal life expectancy. This is a 48-year-old with Duchenne muscular dystrophy also. Now, as you may have heard, this is a very common disease. And these patients, if they're not using a ventilator, they essentially are dead by the average age of 19, and rarely up to 25. But anyway, he has been using 24-hour non-invasive ventilation for 25 years. Now this is a 29-year-old girl who was actually engaged to be married and was diagnosed with Lou Gehrig's disease. Now, Lou Gehrig's disease is different from any other neuromuscular disease because it not only wipes out the throat muscles, what we call the bulbar muscles, but it causes spasticity in the throat that makes it impossible to use non-invasive ventilation. In fact, this is the difference between this condition and all the congenital myopathies. There is no spasticity in the congenital myopathies, just as there is no spasticity in the little SMA1 babies I was telling you about. So even though they have no bulbar muscle function at all, these little SMA1 children, and that got to be 20 years old, unlike the ALS patients, they never need trach tubes. However, the ALS patients, to survive, they do eventually need trach tubes because the spasticity of their throat closes their throat, and they can't, and the cough assist will not work to bring out secretions. At any rate, this was a very brilliant, courageous young woman. She graduated our dental school but was never able to practice dentistry. Her fiancé and she married, and about a year after they got married and after she was using mouthpiece ventilation like this and nasal ventilation at night, her throat muscles got weak, but instead of saying, yes, give me a trach tube, she stuck to her gun, so to speak, and she died. I have the greatest admiration for her. So anyway, this is another ALS patient, the same story. She used 24-hour non-invasive ventilation for about a year and a half, but she was a very meticulous woman. She was the queen bee in her home, and when her throat muscles got very weak, she refused to get a trach and she died. But again, this does not happen with any congenital myopathy, amazingly, or any muscular dystrophy, or even spinal muscular atrophy type 1. No other patients with neuromuscular diseases ever need tracheostomy tubes. This is a patient who got polio in 1954. And she's in the iron lung. She's 9 years old. Here she is when I met her in 1977. She has a sip and puff control motorized chair with the mouthpiece right next to the sip and puff controls. And this is what she looked like a couple of months ago. She has been on non-invasive ventilation 24 hours a day for 59 years. And I have others also 57, 58 years, 24 hours a day, 0 hospitalizations. She, of course, will never need a tracheostomy tube, as does no one else with spinal cord injury or polio or neuromuscular disease. But doctors simply do not know that. There is no incentive to avoid people from going into respiratory failure and having invasive interventions because that is what is paid for. There is no pay to keep people healthy. This is a man with lung disease who can walk around, but he can't breathe. So he has the vent on the chair, on a tray, on his walker, and is able to go. He went 16 years like this and worked full-time as an accountant. He had 7 ventilators. He had 3 in his home, 3 at work, and 1 in the car. In fact, one time the police stopped him because they thought he had a hookah pipe. And he was taking his air through his mouthpiece while he was driving, and the police didn't know what he was doing. This is another lung disease patient, the same kind of story. This is a patient whose trach tube we're removing. And to do that, we show them how to use non-invasive ventilation. And after they use the ventilation, we take the trach tube out. And we generally do this in the outpatient clinic. Anyone with a trach tube with neuromuscular weakness can have the trach tube removed. It shouldn't have been put in the first place, and we offer the option of removing it. Usually we can do it as an outpatient. Now, I showed you a patient who's been using non-invasive ventilation for 59 years, 24 hours a day. We have over 100 Duchenne patients who have been using it 24 hours a day for as much as 29 years. We have SMA kids, about 70 of them on 24-hour non-invasive ventilation. I have 4 or 5 patients with central nuclear myopathies, all on 24-hour non-invasive ventilation. But one of my colleagues in Belgium published a paper on Duchenne, on all of his patients on non-invasive ventilation, and somebody from Paris wrote, non-invasive ventilation via mouthpiece should not be viewed as an alternative to tracheostomy. Determining the best date for tracheostomy in patients with Duchenne remains a challenge. It'll always remain a challenge because it is never necessary, and the man who said that was a chain smoker and died from lung cancer, even though I told him that would probably happen if he didn't stop smoking. At any rate, so this is the main thing that pulmonologists don't understand, that anyone with a respiratory impairment has either lung or airways disease, which is what doctors are used to, or a failure of ventilation. Now, people with a failure of ventilation should not be evaluated and managed like people with lung disease. But in general, pulmonologists don't think in terms of muscles, unfortunately. And so they send patients for pulmonary function studies, which are completely useless because they don't measure cough flows, they don't measure carbon dioxide. Sometimes they do arterial blood gases, which are painful and make you hyperventilate from the pain. All of these are not appropriate with muscle weakness. They also don't do spirometry or vital capacity measurements with people lying down. And it's when you lie down that it's far more important than when you're sitting, because underventilation begins during sleep. So number one, people with weak muscles should be evaluated differently, and they should be treated differently. And above all else, they should not be given oxygen, because oxygen will turn off your breathing and cause your carbon dioxide to go higher and eventually cause patients to arrest, go into respiratory failure. So what are the respiratory muscles? They are the inspiratory muscles, the expiratory muscles, and the bulbar innervated muscles. The inspiratory muscles are basically your diaphragm and your chest muscles. Your expiratory muscles are mainly your abdominal muscles. And your throat muscles are the bulbar muscles. They're needed to protect the airway and to hold the pressure to cough with. So you take a deep breath, your throat, your glottis holds that pressure, and that permits you to cough effectively so that you don't get pneumonia when you get a cold. The thing to understand is that a normal breath is a half a liter of air, but a normal cough is 2.5 liters of air. So if the vital capacity, the ability to take a deep breath, if that is very low, you may have a normal carbon dioxide and normal ventilation, but you're not going to have a normal cough. So very often what happens is that people don't necessarily go into ventilatory failure. They get a cold and develop pneumonia and go into respiratory failure. And then when they're intubated and the doctors think that they are not really able to breathe on their own, they tell them that they have to get a trach tube. And then when they get trach tubes, they never breathe again on their own. Whereas if you don't get a trach tube and we extubate you to non-invasive ventilation, patients invariably wean back to what they were using before they got sick. So it's important to understand the inspiratory, the expiratory, and the bulbar muscles. Now, the inspiratory and expiratory muscles can be zero. You can be completely paralyzed below the neck, have zero vital capacity, no ability to cough at all, and not have any problem at all, just like the woman I showed you for 59 years. Because you can get deep breaths through a mouthpiece, and you can have someone press on the belly, and even use a cough assist to help you cough, to have an effective cough. So you don't really need your inspiratory or expiratory muscles. And you certainly don't need a trach tube, even if you've got no muscles below the neck. But you do need your throat muscles. If you cannot speak or swallow food, and then you cannot protect your airways so that you're constantly aspirating saliva, usually people then need tracheostomy tubes. Now, if you're positioned properly so that the saliva doesn't go into the airway, like the SMAI patients, then even they don't need tracheostomy tubes. But as I said, the ALS patients eventually do. The pulmonary function studies measure everything but what's needed for people with weak muscles. And bronchodilators are not really helpful. Routinely, they're completely unhelpful. Maybe when people are sick, they think it might help them cough a little bit by dilating their bronchi. There's no harm taking it. Normal oxygen saturation is 95% or more. If you artificially keep it normal by giving oxygen, what you're doing is putting a Band-Aid on a cancer. And the cancer, which can kill you, is underventilation and airway secretions that are, if they're not being taken care of, you're going to be in big trouble. Also, patients who do sleep studies, their sleep doctors tend to prescribe CPAP, which is completely useless if you have weak muscles, or BiPAP at low settings. which helps a little bit but is not the way to go because it doesn't rest the muscles adequately, and it does not normalize the carbon dioxide at the low settings that the sleep doctors use. What needs to be done is you measure the carbon dioxide. Now, the carbon dioxide is measured with this little capnograph by sampling the air you exhale at the nose. It's totally painless, and it's the most important thing to measure. Sometimes we measure the carbon dioxide during sleep also. When I'm not sure if a patient is symptomatic, I'll often measure the carbon dioxide during sleep, and if the CO2 is high, I'll try to convince the patient to try nighttime ventilation. And if they don't want to use it, it usually means it doesn't help them very much, and I tell them just to come back in 6 months and we'll check them again. An oximeter, of course, can be used during the day as well as at night, and it never goes below 95% when we're awake. At least it shouldn't. If it's less than 95%, there are only 3 possibilities. The carbon dioxide is high because you're not breathing enough, which can be completely corrected by using nighttime ventilation or ventilation, non-invasive ventilation. There are airway secretions that, if you don't remove them, will probably turn into pneumonia and respiratory failure. And if it stays less than 95%, despite using the ventilator and mechanical cough assistance, then you probably do have pneumonia, and that's when you need to go to the hospital. Besides the capnograph or the CO2 monitor and the oximeter, this is a peak flow meter that measures the cough flow. You cough through that, and you can do an unassisted cough or a cough assisted by getting a deep volume of air with somebody pressing on the belly. That's actually the most important cough, the manually assisted cough, because that tells me the health of the throat to hold pressure and to protect the airway. It's a little bit complicated, but the cough flows are very important. This is a spirometer that's used to measure vital capacity, and it really needs to be measured sitting and lying down, and for people wearing braces, with the braces on and with the braces off. And it should be measured with you there with the doctor so that the doctor has that information immediately and can treat, can write what you might need to help you. Sending people for pulmonary function studies is not only a waste of time and money, the doctor doesn't have the information that he needs right there to help you. Common errors are misinterpretation of symptoms. If someone's able to walk around and they have limited respiratory reserve, they complain of shortness of breath. But people in wheelchairs usually don't. They usually complain of anxiety and inability to sleep. And the reason for that is that when we sleep, we don't recruit our accessory breathing muscles, so it's harder for us to breathe during sleep. Also, our drive to breathe is lowered, and our cough threshold is lowered. So if someone has a cold and very little respiratory reserve, they're going to go to the emergency room and say, in their wheelchairs, they're going to say, well, I haven't slept in 3 nights, I'm exhausted and I'm anxious. The worst thing to do is to give them a sleeping pill, which often does happen. And the next worst thing to do is to give them oxygen. You check the oxygen saturation, and if it's low, you normalize it by normalizing the ventilation and the secretions. The second most common error is inadequate pulmonary function testing. As I mentioned, they're useless. You need the CO2, the oxygen saturation, the spirometry, and the flow meter for cough flows. We monitor sleep with the oximeter and the CO2. That's all that's ever needed for people with weak muscles. We never need to get arterial blood gases. They're painful. They give no additional information that's of any use, and people hyperventilate from the pain, and that causes them to cause their CO2 to artificially go down. Also, as I mentioned, nobody ever needs a tracheostomy tube except for the bulbar ALS patients, or if you aspirate so much saliva that you can't keep your saturation, oxygen saturation, 95% or more when you're awake, which is extremely rare in neuromuscular disease. There's an over-reliance on suctioning. People try to suction, sticking suction catheters through the nose or mouth into the lungs. That's like torture, and it's not very effective. There's a non-invasive method of suctioning that works much better because it gets both the left and right side. You see, even if you send a suction catheter down a tracheostomy tube, 90% of the time it does not go into the left airways because of the anatomy of the lungs. So suctioning is not the most effective way to do it, deep lung suctioning. And for oxygen therapy, don't even think about it until you've tried to normalize the oxygen saturation by normalizing the ventilation and using mechanically assisted coughing to help patients clear their airway secretions. Now, symptoms of carbon dioxide retention are many, including fatigue, difficulty thinking, sleepiness during the daytime. Dr. Olschuler? Yeah. And all these symptoms that I put on here. These are symptoms of CO2 retention that get worse if you put somebody on oxygen. There is no excuse for that. Why not simply put a trach tube in everybody? Well, you know, a trach tube is a foreign body that always is colonized by bad pathogenic bacteria, always. Doesn't matter how many antibiotics you take, you will never get rid of the bad bacteria. And anyone with a trach tube has as much bad bacteria in their lungs as people with acute pneumonias. And that's what that says in this paper here and a number of other papers that have come out. Also, people with tracheostomy tubes are always asked for more air because the air is bypassing the upper airway. And so their carbon dioxide levels go down and they are hyperventilated. Now, if you're hyperventilated and somebody disconnects you from the ventilator, you get short of breath very quickly. This is why patients with trach tubes become continuously respirator dependent for a lifetime, whereas when we remove the trach tube, the patients wean from the ventilator and only use non-invasive ventilation at night when they sleep, provided that their vital capacity is at least 250 milliliters, which is really very little. Also, invasive ventilation makes the diaphragm weaker by deconditioning it. And 17 to 65% of patients with tracheostomy tubes develop tracheal stenosis, which is narrowing of the trach tube. And I guess you can see that if I position it here. The trachea is actually closing here. Once that happens, we can't take the tube out anymore. Other complications of the tracheostomy tube include hemorrhage, fistulas, which are connections between the esophagus and the trachea, abscesses, mucus plugging, all of these. 4 out of 5 people with tracheostomy tubes die because of the tracheostomy tubes, usually after about 7 years on the average. And this is what we found with our ALS patients. Since they had to get trached to survive after a certain point, we found that they basically survived another 6 or 7 years on the average. However, we have one patient now approaching 20 years on trach ventilation with ALS. And I did have a Duchenne patient survive from 19 to 48 years of age, 29 years on trach ventilation. So you can also live a long time on trach ventilation if you're lucky. But why would anybody want a tube in their necks when it's unnecessary? The answer is that nobody does. What patients who had trach tubes who were 24-hour vent dependent, and we removed their trach tubes, then we asked them which they preferred. Well, they all preferred the non-invasive ventilation because it's easier for them to swallow, to sleep, to speak. It's better in appearance. It's more comfortable, more convenient, and they feel more secure. And they prefer it overall. In fact, nobody ever wanted to get trached again, and only the ALS patients actually did have to get trached again after we took their trach tubes out. You know, this is really amazing in a sense. Imagine all these patients feeling more secure without a trach tube than with it. You can ask 1,000 doctors this question, and 999 will say that they're more secure with the trach tube. Now, when you have a trach tube and you're ventilated through with a respirator, you're always afraid that the respirator is going to stop all of a sudden, or you're going to be accidentally disconnected and nobody's going to hook you back up. Whereas if you are ventilated non-invasively 24 hours a day, we can teach you how to frog breathe, to glossopharyngeal breathe, and 2/3 of patients with good throat muscles will be able to ventilate their lungs all day long without a respirator just by using their throats to breathe. You can't get more secure than that. We've had patients wake up at night frog breathing, and then they realize that their ventilator is not working anymore. And so that's perfectly safe, you see. You don't have that option when you're being ventilated through a trach tube. And if someone goes with a neuromuscular condition complaining of anything, and they go to a doctor, and the doctor puts them on oxygen and sends them home, they come back in respiratory failure sooner than if they're not treated at all. You're better off doing nothing than putting patients on oxygen and sending them home. In fact, we showed this in a study of 720 patients years ago. And patients on ventilation via trach tube versus 24-hour non-invasive ventilation, of course, the patients on non-invasive ventilation had far fewer hospitalizations and respiratory complications than the tracheostomized patients. And I showed you this. This is how we evaluate the patients. Okay. Now, the vital capacity reaches a peak at the age of 19, and then for all of us, it goes down by 1% or more per year. However, if you start off lower, now there are some congenital myopathies and muscular dystrophies that are static conditions, which means they're not progressive. Most are somewhat progressive, but everybody has a progressive condition by the age of 20. After the age of 20, everybody's vital capacity goes down. Even in a congenital muscular dystrophy, for example, which is usually not a progressive condition, the vital capacity goes up until you're about 19 or 20 years old, and then it goes down. But it doesn't go up to the normal level. So whatever the vital capacity is, it reaches a plateau at one time, and that may occur from 1 year of age or less to 19 years of age, or any time in between, and then it starts going down. Now, the later the plateau, the better off you are, because it means that you have better respiratory function. This is a graph of patients with muscular dystrophy who, after they plateau, lose 5 to 10% of their vital capacity per year, and by the age of 20, need to use ventilators. And as their vital capacity goes down for anybody, when it goes below about 40% of normal, the cough flows become ineffective. The treatment goals are to do range of motion of the chest wall and lungs, to mobilize the lungs. Number 2, to increase the cough flows. And number 3, to maintain normal ventilation. Now, how do we do that? Number 1, the range of motion is provided by this ambu bag. If your vital capacity is 500 milliliters, but it's supposed to be 5,000, it means you're only inflating 10% of your lungs, which means the other 90% is closing down. If the other 90% is closing down, the lungs and the chest wall get very stiff and rigid. And if you give oxygen too, and the carbon dioxide goes up, then the lungs get rigid at a volume that's even less than the volume you need to get a normal breath to maintain a normal ventilation. So it's very important to expand your lungs to their predicted inspiratory capacity. And that's what we use the ambu bag for. The ambu bag's about $35, and this patient with a vital capacity of 400 milliliters is able to air stack up to 2,000 milliliters just by taking a volume and holding it, and getting another volume on top of that and holding it with the throat. Anybody with a vital capacity less than 80% of normal should be doing this mobilization technique. Again, we're just inflating him. Now, this is a man who, at 48 years of age, had 0 vital capacity, but could get 1,700 milliliters into his lungs by air stacking like this, even though his glottis was a little bit weak, as it is in Duchenne muscular dystrophy. And once you get that deep breath, you blow it into the spirometer. That's what we call the maximum insufflation capacity, and that is entirely dependent on the strength of the throat. In fact, the vital capacity is not dependent on the strength of the throat, only the inspiratory muscles. So let's say your vital capacity, you can have a vital capacity without even closing your throat. So let's say that it's 500, and you're able to air stack up to 5,000. Well, the difference between the two is dependent on the strength of your throat, your glottis. In other words, what we call the bulbar innervated muscles. That is the difference between the insufflation capacity by air stacking and the vital capacity is a direct function of the strength of the glottis and the bulbar muscles. And also, not only does that mean that the stronger they are, the better you are doing non-invasive methods like this, but also it means that you're not aspirating food, you're able to protect your airways, etc. Now, again, this is another test, the spirometric test, that is simply not done in pulmonary function laboratories because, again, the doctors that would send you there do not understand really the important issues to evaluate in patients with neuromuscular weakness. If the lips are the limiting factor in air stacking, then we air stack using a lip seal to bypass the lip weakness because we're really trying to look at the strength of the throat. And if you can air stack to 2,000, let's say, you can usually frog breathe to close to that. Now, what is frog breathing? Well, if any of you have any pets at home, you probably haven't learned much from them unless you have a little frog. So I recommend that you consider getting yourselves frogs, and they'll teach you how to breathe with your glottis, your throat. And you use your back of your tongue, you push a bolus of air past the glottis, and what you can do is, now each one of these little inflections is a gulp of air into the lungs. This woman's vital capacity is over 900 milliliters, but she's able to frog breathe up to almost 3,000. This permits her in the middle of the night to get a deep breath to cough with without having to call anybody for help. And here's a patient with zero vital capacity for 52 years who's able to go all day long without using his respirator simply by frog breathing. And he's one of the people who woke up at night to discover his respirator was not working by frog breathing. Zero vital capacity for 52 years. And this patient with muscular dystrophy, even though his vital capacity went to zero in his late 40s, his frog breathing ability, which gave him freedom from his ventilator for many, many years, also went to close to zero in the last few years. But look at his air stacking ability. He maintains it at 1.7 liters, which means his throat is excellent, which is why you would never need a tracheostomy tube. Now, how do you expand the lungs of a baby who cannot cooperate? Very simple, by putting them on nighttime nasal ventilation and seeing that with every breath, as the belly goes out, the chest goes out too, so that the paradoxical breathing is gone. That's what you do. And instead of having lungs like this, a completely poorly managed child, you end up with more normal-looking lungs. And this is actually one of the two brothers that I showed you earlier with SMA type 1. And this is the brother who's 19 years old now. The second goal is to normalize or optimize the cough flows because mucus plugging is what causes pneumonia and all of the problems, like lung collapse, etc. So 90% of episodes of respiratory failure for any child with neuromuscular disease and for most adults with neuromuscular disease occur during respiratory tract infections because people are too weak to cough effectively. This is when people go into respiratory failure. And as I mentioned, you need to take a deep breath with your inspiratory muscles, create abdominal thoracic pressure with your chest and abdominal muscles, hold that pressure with the throat, and then you have an explosive decompression as you cough. So we pump the patients up there. This is a spinal cord patient. Press on the belly, and we measure that flow. You can even use your head if your arms are weak. As long as you press on the belly, that's the key. And measure that assisted cough flow. So even though the unassisted flow might be close to zero or zero, the assisted flow can be very effective. And this is what I mean. The unassisted flow is on the left, and the assisted flow is on the right. And this is the main image why we never even have to think about tracheostomy tubes in our clinics. This is a cough assist, one of the original ones, that's being used on a 2.5-year-old to get her trach tube out. Now, this is a machine that gives you a deep breath, the pressure drops suddenly, and that creates 10 liters a second of flow, like a cough, to bring secretions out of the airways. A 72-year-old, and you can see the big lump of mucus that came out of his airways by using the cough assist. This is a spinal cord patient who's 15 years old, 2.5-year-old, getting her trach out. This is an interesting patient. She had the strength to use the cough assist independently. And she, failed 2 extubations in another, without them contacting us. It was actually, unfortunately, in our hospital, but they didn't contact us. And then when we went over and gave her the cough assist, we were able to extubate her successfully. This was more than 20 years ago, and she's fine. She still uses her cough assist every time she gets sick. This fellow here was only dependent on the ventilator during the daytime because he did not let us take his trach tube out, because he knew that in 1 year, if he collected enough money, raised enough money, he would be cured. But even though he kept his trach tube and remained dependent on the ventilator because of it, everywhere he traveled, he brought with him a cough assist because he knew that using the cough assist through the trach tube was much more effective because he could get both the left and right lungs, whereby suctioning through the trach tube was uncomfortable and ineffective by comparison. One of the most common mistakes is to use the cough assist at grossly ineffective pressures. The pressures must be 40 or more in general. And also, you must apply an abdominal thrust during the negative pressure. Otherwise, it either won't work at all or it'll work very little. Very few people understand this, but that's the way it is. Very few doctors understand that. The third goal is to maintain normal ventilation, because a weak diaphragm is like a weak horse that will collapse eventually if you don't use a ventilator like a pickup truck so that you can breathe better during the daytime. And when I say ventilator, I mean ventilator. Now, BiPAP is a ventilator, but it's not used like one. Although the inspiratory pressure is helpful, the expiratory pressure subtracts from the inspiratory pressure in terms of helping the diaphragm get and the lungs get a deeper breath. So, for example, BiPAP at 20 inspiratory pressure and 4 expiratory pressure gives you exactly the same boost to your breath as 20 and 0. 24 and 4 is the same as 20 and 0, but which is more comfortable? Obviously, the 20 and 0. So whatever the BiPAP is, the IPAP has to be set higher to get an effective breath and to maintain normal carbon dioxide very often. But again, sleep doctors don't understand this at all, And even intensive care doctors, very few understand it. They extubate people who are too weak to breathe to low spans of BiPAP. They fail extubation and then tell them they need trach tubes, which is completely wrong. So we do not use BiPAP except for ALS patients who have no bulbar muscle function, because ALS patients with no bulbar function cannot air stack because they cannot close their glottises to hold the air. That's why we use volume cycling, preferably, on portable ventilators like the LTV or the Trilogy ventilator. Unfortunately, I don't have a Trilogy or a Newport image right now, but all of them are equally good, and they can be used on volume cycling. This is an important image, so I'll let you copy this down for a few minutes. These are the opinions on when to start nighttime ventilation. And when there are multiple opinions, usually they're all inappropriate. The only reason to start or offer nighttime ventilation is for patients who are symptomatic from underventilation. If someone is not symptomatic, they don't need to use nighttime ventilation. And if they are symptomatic, they will use it. And if they're not symptomatic, they're not going to want to use it anyway, which is fine. Then I tell the patients to come back in 3 or 6 months, depending on the diagnosis, and we recheck them to see if they're more symptomatic in a few months, and then they will use the nasal ventilation. So the indications are paradoxical breathing for small children and symptoms of underventilation. Don't bother with negative pressure. Iron lungs and chest shells like this never work as effectively as nasal or mouthpiece ventilation, because the negative pressure causes the throat to collapse as you're inhaling, and you get obstructive apneas. The air doesn't make it well into the lungs. Everybody's got a different shaped nose, so don't expect the least expensive nasal interface to work for everybody. A good interface should be leak-free, comfortable, and maintenance-free. Also, you must avoid oxygen and sedatives. And no alarms are needed as long as you avoid oxygen and sedatives. The best alarm is the brain, period. That's all that you need. You're not going to arrest because air leaks. It just doesn't happen. What happens for a few people is that if you're being ventilated through the nose at night and all the air leaks out of the mouth, you could have brief arousals to stop the leak that you're not aware of, and generally people are not symptomatic for that. But if people are, or so for example, if you wake up and they're a little short of breath and then you have to close off the leak and go back to sleep, the solution for that is to use ventilation through the nose and the mouth, which I will show you. Nasal ventilation, there are all different types of nasal interfaces. And for babies, we make our own, but Respironics has infant interfaces too. This is a nasal prongs unit. This is nasal prongs that we constructed. Other nasal prongs and so on. Now, when you're using nasal ventilation, the air can leak out of the mouth and the saturation could go down and the carbon dioxide can go up if you leak too much. So again, you can have a sawtooth pattern of desaturation from leak, and sometimes the desaturations can be severe. The solution is not to try to stuff the mouth because the air leaks around the bite plate. The solution is not to tape the mouth because the saliva forces that off every 10 minutes. The solution is to ventilate through the mouth, either with a lip seal or, even better, to use something like a Liberty or a hybrid interface, which is nasal prongs with a lip cover. This is a closed system, like a trach tube with an inflated cuff. It works great, and you can even take oxygen if you need it without excessive leak occurring if you're using a closed system like this. But normally, if anybody needs oxygen, they have severe lung disease, and they are not likely to benefit from non-invasive ventilation. And this will normalize your ventilation and oxygen saturation. Now, what is mouthpiece ventilation? Well, in 1530, the Italian physician Paracelsus took his chimney bellows and inflated his patients who were short of breath or deceased. And for 300 years in Europe, that's what doctors did. If their patients were short of breath, they would get their chimney bellows and inflate them. Alveolar hypoventilation can also be compensated by making a greater effort. So if a patient has a low saturation and a high CO2 and they're not strong enough to normalize it very long, they can normalize it by getting a deep breath through a mouthpiece like this, you see. And now, interestingly, Dr. Affeldt from Ranchos Los Amigos in 1953 said, some of our physical therapists in struggling with iron lung patients noticed that they could simply take the positive pressure attachment, apply a small plastic mouthpiece, and allow that to hang in the patient's mouth. We even had one patient who has no breathing ability, who has fallen asleep and been adequately ventilated by this procedure so that it appears to work very well, and I think does away with a lot of complications of difficulty using invasive positive pressure, trach tubes. You just hang it by the mouth, and they grip it with their lips when they want it, and when they don't want it, they let it go. It's just too simple. And then he goes on to say, I don't know why this was not done a long time ago. Now, this was written in 1953, and physicians still are not using this, okay? So, all right, these are the guys with the mouthpiece ventilation singing with their group and all these different mouthpieces. Some people keep the mouthpiece in their mouths, and they have no problem speaking or eating anyway, next to sip and puff control wheelchairs, next to a chin control motorized chair. Now, this flexible metal support arm is very important because people using joysticks on motorized wheelchairs, this is the way they use their mouthpiece ventilation, or with a microphone holder. Now, another device which is very helpful is an intermittent abdominal pressure ventilator, also known as a PNEUMOBELT or exsufflation belt. It's a girdle with an air bladder in it that, as it gets pumped up, pushes against the belly, moves the diaphragm, and ventilates the lungs. This air sac is attached to the ventilator on the back of the chair, so there's nothing in the nose, the mouth, or the neck. But patients with zero vital capacity can use this all day long, and they do. And you see, you can't even tell that the patient's using a respirator. He has zero vital capacity. He's got sip and puff control motorized wheelchair, but you can't see his ventilator. It's behind his wheelchair. You can be measured for it, and it can be custom made, but you need a powerful ventilator to inflate it. And these days, the ventilators are not powerful enough for most people. So we have to get an old ventilator to operate these. As I mentioned earlier, when patients get sick, the first thing to do is to put the oximeter on and to always maintain the saturation 95 or more when they're awake. Now, when we're asleep, we all go below 95. And if patients can sleep, I don't worry about them, because their brain will prevent them from arresting as long as the patients don't get oxygen or sedatives. But when you're awake, if the saturation is less than 95, it's either because of underventilation, for which they must use their non-invasive ventilation, or airway secretions, for which they must use their cough assist with the abdominal thrusts. And if they still can't get that saturation back to 95%, they've got pneumonia, and that's when they need to go to the hospital. By the way, when they do go to the hospital, I tell them, no matter what the doctors say, just simply do not give consent for a trach tube and have them call me, and we'll get you transferred here, or I'll send them a copy of the article about how to extubate patients with weak muscles who are not weanable from ventilator use. Usually they'll be afraid to do it, and they'll want to send the patients to us anyway, but that's fine. That's fine. We get patients transferred here multiple times per week. And this is a 72-year-old woman, flew in from Warsaw, fell down her daughter's steps, broke her neck, was intubated and on a Friday, and I came back from being away for a few days, and we extubated her on Monday. But when patients are intubated, you see, the doctors look for this before they take the tube out: an adequate cough, absence of airway secretions, and the ability to breathe with minimum assistance. Of course, patients with weak muscles don't have an adequate cough, cannot clear their airway secretions, and cannot breathe with minimal assistance. And they even say here they should have an adequate cough, few secretions, and should tolerate a low level of ventilatory assistance for a prolonged period of time without fatigue. Now, this is completely inappropriate for patients with muscle weakness. Completely useless. And this is why all these patients are told they need trach tubes, because the doctors do not know how to extubate them. I'm not going to go through what the usual method is, but let me just tell you that the usual method includes patients getting oxygen all the time, before extubation and after extubation, and being extubated without full non-invasive ventilatory support or the use of mechanically assisted coughing. And because they don't get what they need and they fail extubation, it's not a surprise that they end up getting re-intubated and the doctors tell them they need trach tubes. So anyway, our patients, we extubate them to full non-invasive ventilatory support. In this case, it was with a lip seal, and we also use nasal ventilation for her and mouthpiece, and we use the cough assist to clear her airway secretions. We have criteria where the lungs must be healthy, the saturation normal, and then we extubate, and there should be somebody from the family or a care provider around to use the cough assist up to every 30 minutes after extubation for the first 24 hours. Because in other places, patients fail extubation because they can't clear airway secretions. And we really can't expect the nurses and therapists to use the machine every 30 minutes, because even in intensive care, it's not exactly one-on-one nursing. So and also the family needs to know how to help the patient so that next time they get sick, they don't have to come to the hospital. So we pretty much insist that somebody come to stay with the patient for the first 24 to 36 hours to help them cough after the extubation. We remove the nasogastric tube if there was one present, because if the patient was eating before they got intubated, they're going to be able to eat afterwards. Anyway, we can always put a tube in without intubating the patient. By the way, in other places, they often want to intubate patients to put in stomach tubes, but it can be done without that, and we do it without that. And anyway, our method is to extubate to full non-invasive ventilatory support. Now, in 2010, we published a paper on that, where we extubated 155 out of 157 who failed extubations elsewhere and were not weanable, could not breathe on their own. All of them were told they needed trach tubes. 100 of them were transferred here from other hospitals. Many came from other countries, from Iceland, from Qatar, et cetera, and Hong Kong. And anyway, the only two patients that failed were patients with bulbar ALS. And that's understandable. Since that time, by the way, we've had another 120 patients come here to be extubated where they were told they needed to be trached elsewhere. What were the diagnoses? ALS, Duchenne muscular dystrophy, critical care myopathy. Now, these are people without neuromuscular weakness who were in the critical care units for a month or more and got so weak from being so sick that they were too weak to breathe, and they were told they needed trach tubes. But again, they didn't have any neuromuscular condition. Non-Duchenne myopathies, congenital myopathies, 20, myasthenia gravis, 13, post-polio, spinal muscular atrophy, spinal cord injury, and other non-neuromuscular conditions. Those were the diagnoses. Besides extubating people who are too weak to breathe, we also routinely remove the trach tubes of people who are too weak to breathe. And we published this over 20 years ago. You know, this is an ALS patient whose trach tube we removed. Our respiratory therapist, Lou Saporito, takes the tube out, puts on a pressure dressing. Here we are air stacking the patient to measure the cough flow, because if the cough flow is adequate, 160 liters a minute, I know the upper airway is open, and we will definitely not have to put the trach tube back in. But if the cough flow is close to 0, I will not leave the trach tube out, because that means that the upper airway is not open. And so we have an ears, nose, and throat doctor look inside and see if there's something that can be removed, like granulation tissue, for example, before we keep the trach tube out. So there's tegaderm or a duoderm on the ostomy, and then we put a cane tip on that, some tape, an ace bandage, and the patients ventilate themselves around the clock without the air leaking out of their necks. And the ostomy closes generally within 3 days. So we have over 100 Duchenne patients on 24-hour non-invasive ventilation, 72 spinal muscular atrophy type 1 patients on 24-hour non-invasive ventilation. We got together with some other centers in other countries. There are 760 people with 3 diagnoses, common diagnoses, Duchenne, ALS, and SMA type 1. And we've reported that. There are no other centers in the United States, by the way, that do this. The closest center is in Toronto, Canada, that does this. I'm sorry, not Toronto, Ottawa, Doug McKim up there. But there are no other centers that I know of that actually does this in the United States. So for a spinal cord patient, now this patient was going into ventilatory failure and was short of breath. But instead of being intubated, we simply ventilated him with nasal ventilation, showed a mouthpiece ventilation, lip seal, and he had a chest shell on. The chest shell was removed. The neurosurgeon placed a brace for his neck, and he ventilated himself like this. He never developed any airway secretions because he didn't have an invasive tube in his throat. His vital capacity came back after a couple weeks. He went to rehabilitation, and he got much better. He never needed to be intubated, even though he couldn't breathe at all for 4 days. So what are the indications for a tracheostomy tube? It's very simple. If you aspirate so much saliva that your oxygen saturation cannot come back up to 95%, despite having normal ventilation and using your cough assist, you need a trach tube to survive. In fact, 90% of ALS patients for whom this occurs will not survive 2 months without a trach tube. But I have never seen this happen in any other neuromuscular disease, not even spinal muscular atrophy type 1 or infantile Pompe's disease, which is extremely severe as well. This is this website was started by Rich Klingman, who is the friend of a man who has a son with muscular dystrophy, and he wanted to do something for his friend, and Rich is a computer nerd, and so he contacted me, and he set up this very nice website to inform people with neuromuscular disease. I also have a website with my medical school here, which is basically the Rutgers, New Jersey Medical School, but I rarely look at it. In fact, I rarely look at any website, but Rich basically does a good job and keeps this fairly up to date, and this is the one that most people look at because it's easier to remember, drbach.com. It's doctorbach.com, though. I've had 7 books, and this is the last book, and this book is, more than half of it is respiratory, but the other parts are every other aspect of neuromuscular diseases, cardiac management, equipment, orthopedic management, how to put in gastrostomy tubes without general anesthesia or intubation, etc. So this book is still, I estimate, at least 50 years ahead of its time. I only say that because nobody else in the United States is really picking all of this up. And the main reasons for that, I believe, are financial, but there's another very important reason. Doctors tend to either work with children or adults because their insurance doesn't cover them for both. So that when kids become adults, they have to get an entirely different team of physicians. Now, the pediatric physicians may know what they're doing, but it's not likely that the adult physicians will, or vice versa. And this is what makes a problem in the care of patients with neuromuscular disease. People in the specialty of physical medicine rehabilitation, my specialty, take care of both children and adults. So I see kids who are born with SMA, and I see older people with ALS and so on. And that I think is a very important reason also. And the other reason is that most neuromuscular clinics are run by neurologists, and neurologists generally don't have a lot of interest in respiratory management. And they often just refer the patients to their friends, the pulmonology friends, but they're not necessarily the pulmonologists who really take an interest in learning how to take care of the patients. There are some pulmonologists out there that really know what to do. Nick Hill is one, Joe Veroslav in Dallas, and Deborah Galinas in California. But they are few and far between, and really there's only a handful, I would say, in the United States. So I can stop right there on the book and open up to questions. Hello?
Yep, we're all here. We didn't fall asleep.
Okay.
You kept us gripped. So, first of all, thank you so incredibly much. I am a total disciple of what you preach. And I'm really excited that this is so well presented that I think also people without a medical background can really follow it and understand what the different issues are and where things go wrong.
Yeah, I have a question. I'm learning more about, I'm a nurse practitioner. I'm learning more about, you know, pulmonary care in patients with neuromuscular disease. And I was wondering, you mentioned that BiPAP volume cycling is preferable to, and I'm sorry, I'm not a pulmonologist, so I don't know all the terms, but to volume cycling is preferable to BiPAP. Is that what you said? I just wanted to clarify.
Absolutely, and let me tell you why. Basically for two reasons. First of all, what's the difference between volume cycling and BiPAP? BiPAP is pressure cycled. That means you set a pressure, the machine delivers air until it reaches that pressure, then it turns off. So if you get a volume of air from BiPAP set at a pressure of 10, let's say that you don't exhale that volume. You're holding that volume, and you want another volume. Okay, so now the BiPAP delivers another breath, the same pressure. As soon as you open your throat to receive the air, it senses the pressure that you're holding, and it shuts off. So in other words, with end pressure cycling, you cannot air stack. You cannot add one volume of air onto another volume, which means you cannot maintain your compliance and elasticity of your lungs. You cannot get a deep volume of air to cough with or to speak loudly or speak better with, or for that matter, even to eat better. So that's why, and the other problem with BiPAP is you can't turn off the expiratory pressure, which is counterproductive, as I mentioned earlier. And usually with BiPAP, you've got to be plugged into a socket. So you can't just put it on a wheelchair and use it for daytime ventilation. And it doesn't go up very high. It goes up high enough to ventilate people, but the fact that you can't air stack with it is the biggest problem with pressure cycling and using BiPAP. So nobody needs expiratory pressure. You cannot shut the expiratory pressure off with BiPAP. So we only use it when patients cannot air stack. And the only patients that is a matter of is the ALS patients with bulbar muscle weakness. Okay, did you get that?
Yes, thank you. And so is volume, you probably have more to say, though. Sorry, I don't mean to interrupt.
No. Go ahead.
Cycling basically different settings on the same machine then, or?
Okay, machines like the Trilogy permits you to use volume cycling, pressure cycling, or BiPAP settings.
Okay.
The LTV allows you to do pressure cycling and volume cycling, but not BiPAP. Now, it gets a little bit technical, but again, any kind of pressure cycling means you set the pressure, the machine delivers a volume until it reaches the pressure that you set it at. So you cannot stack volumes of air. If you set a volume on a volume cycled machine, let's say you set it to 1 liter, the machine delivers a liter of air and you hold that, but that liter of air creates a pressure in the lung, maybe 20 centimeters of water. Now it's set to give you another liter of air. Well, the machine doesn't care what the pressure is because it's not pressure setting. It's set by volume.
Okay.
So it gives you another liter. Now you've got 2 liters, and it'll give you a third liter. It's only limited by the high pressure limit that you set on the machine, which can be 70 centimeters of water or more. So for people who want to air stack, they cannot use pressure cycling on any machine, whether it be BiPAP or a Trilogy or anything else.
Okay.
So we always prefer volume cycling so that patients can air stack, so that they can cough better and keep their lungs healthier.
Okay. Thank you.
Okay. Now,
question. Patients who are cognitively impaired, can you think of a creative way to teach air stacking, or do you think that that is too challenging to teach?
well, for babies who cannot cooperate, what we do is we time a deep insufflation to their inspiratory effort. In other words, when their belly goes out, they're inhaling, so we give them a deep volume of air. And in adults, you can do the same thing. You can give them one deep volume of air instead of have them air stack. So you can set a cough assist at an inspiratory pressure of 50 centimeters of water and give them that deep, deep breath. But if they exhale against it, it's not going to help. So in general, if people can really not cooperate at all, these methods are not going to be that helpful.
Yeah, so you wouldn't necessarily need to air stack as long as they can cooperate with getting one larger volume. But they can't actually hold it, so they're not necessarily sustaining that larger volume over a longer time period. That's the only difference, right?
Well, you're basically right. Now, you know, air stacking goes to a maximum that we call the maximum insufflation capacity. But, as you said, there are people who cannot air stack because, number one, they can't close their glottises. They still need to have their lungs inflated. Otherwise, the lungs close down. So then what we do is we give one deep insufflation using a machine at a high pressure or volume. Typically, we use the cough assist at a very high pressure, 50, 60, 70 centimeters, 60 centimeters of water. And that gives them the deep breath. Now, they cannot hold it because they can't close their glottis, but that doesn't matter. That doesn't matter in terms of keeping the lungs healthy. The air stacking is helpful to keep the glottis strong or to exercise the glottis. So it's still important to get the deep insufflations even if you cannot air stack. But that can be done with a deep line. Now, another way to do it is to get an ambu bag, if you know what that is. It's a manual resuscitator, that $35 thing I showed you in the image there. You can block the valve that the air goes out of so that as you inflate the patient cannot exhale through the machine, through the bag. So you can block the exhalation valve on an ambu bag and inflate one volume after another to expand the lungs. So there are other ways of doing it, and this is what we do in the clinic. We find the best way to expand the lungs. We teach frog breathing. We teach manually assisted coughing as well as mechanically assisted coughing. And our respiratory therapist does all of this in our MDA clinic, you see. So, yes, you can. Yeah.
That the air stacking where a larger volume is maintained for a longer period of time, that the stretch in the lungs and chest wall actually also confers a advantage to basically impairing that decline from the plateau period. So in other words, does the stretch of the chest wall beyond simply the strengthening of the glottis potentially confer an advantage to preventing a further decline in respiratory capacity?
Boy, that's such a wonderful question. The answer is absolutely. Now, I plan on writing a paper about that soon. That's one thing I've never written a paper about, really. But in fact, the vital capacity always goes up after you start these, what I call range of motion or lung mobilization techniques, because the lungs become more elastic. So the vital capacity does go up, but it's not a tremendous increase in vital capacity. It's usually about 10 or 15%. But that's still helpful. That's still helpful because it becomes easier for the diaphragm to move the lungs if you make the lungs more elastic. So the answer is absolutely yes.
Right. Okay. Great. I don't have any more questions. Does anybody have any additional questions?
I have a question. You guys...
I did have one.
Okay, okay.
Okay. Stacey, do you want to introduce yourself?
Sure. Hi, my name is Stacey Cassette. I am a parent of a child with Nemelin myopathy, and I'm also a professional. I work in research, and actually the CMD tissue repository that has just been launched will be under my care and that of Dr. Lawler at the Medical College of Wisconsin.
Do you know Dr. Mahler?
Dr. Lawler.
Oh, it's Waller. Okay, okay. I'm sorry.
Yeah.
I'm sorry. Go ahead. Go ahead.
And the question that I have is based on something that you said earlier. I think your comment was that breath stacking is a very important therapeutic type of activity, especially for anyone at 80% vital capacity or less.
Yes.
So if someone is above 80% vital capacity in general, would breath stacking really not be very helpful for them?
I really don't think, see, first of all, 90% of vital capacity is still within normal limits.
Mm-hmm.
So I really, you know, you've got to draw the line somewhere. Why put somebody through doing a regular activity 3 times a day of these mobilization techniques if they're close to 100% of lung capacity anyway? So, you know, 70 or 80%. And the other factor is how rapidly progressive is the condition. If it's a static condition and the vital capacity is 80%, I'm not going to ask the patient to practice air stacking. But if they've got a rapidly progressive condition, then I'll definitely start it when they reach their plateau or when they get to about 80%. So it depends on the condition, how rapidly progressive it is, or if it's progressive at all. And you have to realize that 90% can be considered within normal limits. But by the way, Nemelin myopathy, like many other congenital myopathies, is a wonderful example of a condition that virtually no one ever needs to get a trach tube, because what happens with Nemelin is that the bulbar muscles stay relatively strong, that the patients can always speak and swallow food for almost always. And what happens is that when they lie down, eventually they get short of breath because their vital capacity goes down when they are supine, when they lie down. So they use nighttime ventilation for years before they might ever develop weakness during the daytime. But because the bulbar muscles stay so good, they do extremely well with non-invasive ventilation. And many other of the congenital myopathies are like that too. The first sign of problem is often when patients start using 2 or 3 pillows, because if they lie on their backs, they get short of breath. But the throat muscles generally stay relatively strong, just as a side comment.
And that does lead me to another thing that I was wondering as well. So this 80% vital capacity, is that while the patient is standing up? Because obviously it's less when they are, you know, sitting or lying down, certainly.
Well, you said obviously, but that's not true. The normal difference in vital capacity between sitting and lying down is less than 7%. When someone with Nemelin myopathy lies down, their vital capacity often goes down by 30 or 40%, or even more. Sometimes the vital capacity when you're sitting could be 3 liters, but when you lie down, it's less than 1.5 liters, and the patients cannot lie flat without using the ventilator on nasal ventilation. And if you don't let them use nasal ventilation, eventually their carbon dioxide will go up even during the daytime. So people really should be using nasal ventilation if they cannot breathe lying flat, because first of all, sitting up and sleeping is not as restful.
Mm-hmm.
Oh, that's another reason why, see, the pulmonary function testing is so inappropriate. They never measure supine vital capacity, which is the most important vital capacity, as I mentioned, because it's during sleep that people begin to underventilate.
Right. Yeah, these are questions that come up a lot among other parents of children with Nemelin myopathy. And oftentimes I'll hear, particularly with new parents, that their doctors are pushing them to get a trach for their new infant, and they're not sure if they should do that or not.
They should definitely not do it.
Yeah, that's what I've been hearing you say.
See, Nemelin myopathy is never as severe as SMA type 1.
Mm-hmm.
I mean, it can be pretty severe in cases, but most of the time it is much milder than the severe SMAs, you know, like SMA type 1. And even in SMA type 1 now, I showed you a couple of brothers who are approaching 20 years of age. We have many patients over 15 years of age without trach tubes. They've got no bulbar muscle function at all. They can barely move their eyes. You know, they can't move their facial muscles or anything since they were infants, and they don't have trach tubes.
Mm-hmm. So it is possible, and I think that when this comes up again, I would like to point them in your direction so that they could have a conversation with you and learn some of this.
Yeah, and in fairness to their doctors, you know, I mentioned that 19 years ago, for 2 of my patients whose parents refused trach tubes, I told them that their kids would be dead within a year, and their kids are still alive today, and one family has a second with the same condition. And it's been 19 years. So I can well understand how doctors can think that the patients need trach tubes. I mean, I thought that and I've been using non-invasive ventilation for adults for 20 years at that point, or 10 years. And yet I was completely wrong when I told the families that their kids would be dead within a year. So again, I can well understand why the doctors think that, but I was wrong and they're wrong too. So that's what it is.
Yeah, and the parents are just very scared. You know, they want to do the right thing. They're trying to gather as much information as they can, but a lot of times the information isn't good information that they're getting.
Great. Well, that's fantastic. We will be in touch. Rachel will send you the link for the webinar and the video, and then we will also post this on the registry, and I'm sure that you will receive calls and emails from parents who have questions, and we will also I think what would be very helpful is perhaps to also transcribe some of the questions and answers so that people could go back and look at that. We can talk about that.
That's fine.
Regardless,
do it by email.
This has been absolutely fantastic. And I just want to thank you so much for spending so much time with us on the phone today and giving such a wonderful presentation. And we're really looking forward to continuing the dialogue on how to improve care for more individuals.
Great. I was very happy to do it. Very nice talking to all of you.